excited to have Dr. Vivekanandhan come and speak with us. I strongly believe that his research is very cutting edge and interesting to us as students as well as faculty. And so if we could please all give a very warm welcome to our first speaker, Dr. Vivekanandhan.
Hello everybody. A very good afternoon to one and all, and thanks Natalie for the nice introduction. First of all, I would like to thank Sergio because he was the first person to contact me and then told me he was interested in the kind of research activities which we are involved in, and eventually I'm here. I would also like to thank the organizing committee for giving me this opportunity. So before taking too much of time, I will right away just go in for the presentation. The topic for today's presentation is extended hygiene hypothesis from allergies to autoimmunity to metabolic diseases. How far can we extend? Now, as you can see, this gentleman who is trying his level to stretch cord. We are first going to introduce you to this new emerging concept called hygiene hypothesis, and then we are going to see how far we can actually extend this hygiene hypothesis to explain disease. Can we have the next slide, please? So I'd like to just start off with these photographs. I'm sure you know the photograph on the right hand side, which is sort of probably more familiar to you. And the photograph on the left hand side actually depicts one of the most crowded roads in Chennai, the place from which I'm coming from. So the question is, does these photographs any relevance to the talk which I'm doing? So can anybody guess the most obvious difference between these two photographs? Exactly. One is sort of overcrowded, the other one is sort of really clean and green and things like that. So the most obvious thing which comes to your mind the moment you see this photograph is hygiene or cleanliness. So as we grow, we have always been taught hygiene is always good for us, right? So the more the hygiene is, better it is. But then the hygiene hypothesis, which I'm going to introduce it to you, says exactly the opposite. What it says is, too much of hygiene is actually not good. Now, hygiene hypothesis is basically an ecological hypothesis which is very recent, which was probably about a decade ago. But what is interesting about this hygiene hypothesis is it was not put forth by a criminologist or for that matter even a biologist. It was in fact put forth by a person who is a hardcore statistician, and it was a serendipitous finding. So let's see how this hygiene hypothesis was synthesized and it was put forth. The hygiene hypothesis was what put forth by a person called David Chachrin, and this was published in British Journal. And he was basically a statistician who was working on an entomology department. So the task which was given to him is to have a statistical analysis of the emergence of a particular disorder in the allergy in London. So he found out suddenly there has been a robust increase in the incidence of allergies in London, and the government was a little puzzled about the concept and they were trying to find out what was happening. And then they just wanted to take the epidemiological census to find out whether the allergies are actually increasing and how much it is increasing, so on and so forth. But being a statistician, this guy got interested in this analysis part, and he found out yes, the allergies are in fact increasing robustly in UK, and one of the major factors which was strongly associated with this increased prevalence of allergies is something which was not biological, but it was social. What is it was? Allergies were more common in nuclear families compared to joint families. And at that time, the significance of this one was not understood by many. People really couldn't take it very seriously. They said this is a sort of a blabbering from a statistician. What does I mean? Right? We don't understand what is, nuclear But then this guy really had a point. So then, over the time when people started working on it, they would really solve this puzzle and try to find out why this was happening. Now think about a nuclear family. In a nuclear family, what typically happens is when a child is born, the child is exposed mainly to his parents who are adults, who are very well educated about hygiene. So whenever these people go out and come back, they take all sorts of precautions, they will washing their hands, taking baths, blah blah blah, and finally reaching out to the child, which means the child is actually not exposed to any of the germs or the pathogens or any microorganisms. So it is sort of being grown up in a bubble or a hygiene bubble. So it immune system doesn't get an opportunity to get trained and to see and to find the pathogens which it is eventually going to encounter later during the life. But what the more devastating thing is, since the learning process of the immune system is not there, the immune system probably tries to fight back, and this leads to sort of allergies or immunity, so on and so forth. Whereas in the joint family, you have children of various age groups. So these children will go out to play, drinking blood, and you really cannot control them. And the child which is born in a joint family is sort of exposed to all sorts of blood, microorganisms, so on and so forth. So it has a better immune system which is more hoped of discriminating between self and non-self. And that is the whole essence of the hygiene hypothesis. So way back in 2004, immunologists got interested in this hygiene hypothesis, and they found out that apart from allergies, autoimmunity is also typically covered under this umbrella. What it means is if you are too protected during your childhood, where your immune system doesn't really see the pathogens or germs and doesn't learn how to discriminate between self and non-self, probably you will run an increased risk of developing allergies and autoimmunity at a later time point. Then, in 2008, when they really started working on immune responses in type 2 diabetes and other metabolic diseases, it was very coincidental, like in 2009, somebody has actually extended this hygiene hypothesis to obesity, but it was just a hypothesis which has appeared in a review article, no hard fact proofs were provided and things like that. Now, what is this hygiene hypothesis has to do for the overall public? Of course, it is an interesting hypothesis, and immunologists do want to work on this hypothesis because there is a strong reason why immunologists have to work on this hypothesis, but does it have any practical implications for the society? Yes, what is so interesting about this hygiene hypothesis is that, in contrast to so many other things, this hypothesis is one hypothesis which immediately went to the bedside of the patients. Let's see how. Now, there are certain very common diseases in the United States like Crohn's disease, ulcerative colitis, and so on and so forth, typically classified as intestinal and inflammatory conditions. The exact etiology of diseases is not clearly known, but again, the hygiene hypothesis goes through here, which means persons who have been following too much of hygiene are at increased risk of developing this intestinal disorders. So somebody thought that, okay, what if there is a strong link between the immune system and the, pathology of the diseases and little bit of hygiene, why don't we actually deliberately dehygienate the intestine and see whether the conditions are coming under control? So what they actually did was they took the eggs of the bone. So they took the eggs of the bone, which is commonly present in the intestine, and these eggs were reintroduced into individuals who are suffering from these diseases. And then the whole idea is to introduce worms into the intestine, which are generally not present because of the too much of hygiene thing or the hygiene bubble, and see whether things come under control. And they found out that this actually offers tremendous amount of help for these disease conditions where there is no treatment option which is really available. In fact, the only treatment option available for this group of diseases is to put them under heavy doses of immunosuppressive drugs, which can actually do more harm to the individual rather than the disease bursting. But now, by introducing the skeletons or the worms into the intestine, none of the side effects which are typically seen with the immunosuppressive drugs are seen, but then the disease was tremendously impactful. So this gave a new hope for immunologists to develop this hygiene hypothesis on the practical lines and to see whether we are able to come up with better drugs and vaccines by using the same principles. Now, this hygiene hypothesis also has a lot to do with what you call it as epidemiology. If you look globally, you can find out globally the incidence of eventually started coming down. Now, this is basically because of the antibiotics, the global amount of antibiotics which we have, and better health practices and better, like healthcare, so on and so forth. But the flip side is, the incidence of metabolic diseases all over the world have started increasing. In fact, diabetes is increasing to such an extent, people have even started calling it as a pandemic disease. The question now is the decline in infectious diseases and increase in metabolic diseases, do they have overlap? Do they have a link? Do they have a common point where they actually meet? And it seems that might be. So certain diseases, when they increase, when there is a decrease in the incidence of certain diseases, then it is compensated by an increase in the incidence of certain other diseases. And this is a fast emerging concept in epidemiology, which is called as disease dynamics. And then you can see, not all countries figure out uniformly this trend. There are certain countries or underdeveloped countries where we still have a huge burden of infectious diseases, but even there, the infectious diseases have started declining, and they have lower burden of metabolic disease. Then there are certain countries like developed countries like USA and UK, where infectious diseases have almost come to very low levels, and you really do not see so many patients suffering from infectious diseases because of better hygiene and healthcare. But the problem here is that tremendous increase, especially in the last decade or so, in the increase of metabolic diseases, especially diabetes and cardiovascular problems. And when it comes to developing countries like India and China, we are actually at the transition of these two trends. So the infectious diseases have started coming down, the metabolic diseases have started going up. So if you really wanted to see the association between this decline and increase, these countries are the best places where we should start looking into our epidemiological studies and associated with basic lab and really find a mechanism and link between these two trends. So taking this clue, I decided to work on the combination of filariasis and metabolic diseases. So in the couple of slides coming up, I will be introducing to you what filariasis is and what are the metabolic diseases which we looked into. Now, I'm not showing this picture to intimidate any of you, but this is just to show how devastating the disease lymphatic filariasis can be. Even though this disease is not life-threatening, it can bring about permanent disfigurement to the individuals and can cause a significant amount of morbidity. Now, filariasis is basically a parasitic disease. Parasitic diseases are very different from other infectious diseases like viral diseases, bacterial diseases, fungal diseases, so on and so forth. For the simple reasons like it is much easier to tackle a parasitic disease compared to life-threatening viral and bacterial disease. The second thing is the kind of immune response that parasitic diseases induce is way different from the immune response that viral and bacterial diseases induce. So, filariasis is caused by a thread-like worm, which typically, lives in the human lymphatic system. It is basically transmitted by mosquitoes, which are very prevalent in tropical countries. It is endemic in 83 countries, and more than 120 million people have been infected. But I should apologize, this figures are almost a decade old. Nobody has actually, looking for these figures currently. So we really do not know, where the filarious pockets are, right? The disease itself is not life-threatening, but it can cause permanent disability and disfigurement. And basically, the adult worms sort of lodge and block the lymphatic blood vessels, leading to fluid accumulation, swelling, and disfigurement. So, taking this clue, as I mentioned before, we wanted to study the interface of filarial disease, lymphatic filariasis, and metabolic disease. So, the diseases which we targeted as diabetes, cardiovascular disease, and something called as metabolic syndrome. I'll tell you more about metabolic syndrome. I'm sure you'll be more used to diabetes, cardiovascular disease, and not to metabolic syndrome. And in diabetes, we looked at both type 1 diabetes as well as type 2 diabetes. So let's start with type 1 diabetes. Type 1 diabetes is actually a bona fide autoimmune disease. So as I told you, certain unfortunate individuals, their immune system doesn't really learn how to discriminate between self and non-self. So what eventually happens is the immune system, rather than fighting the pathogen, starts fighting its own body constituent, and depending upon which body constituent it is fighting against, it results in an autoimmune disease. This is the most simplistic, So in the case of type 1 diabetes, what really happens is the immune system mounts a strong immune response against the pancreatic beta cells. Now the pancreatic beta cells are absolutely essential for our body because they produce the major hormone insulin. And insulin is a very important hormone for survival because insulin is the master controller of metabolism. Apart from keeping your blood glucose levels in the optimal concentration, insulin also plays a very important role in maintaining homeostasis of the body, which would include lipid metabolism, protein metabolism, so on and so forth. So insulin is produced by pancreatic beta cells, and once the pancreatic beta cells are blocked, we will develop diabetes. And in the case of diabetes, the autoantigens are typically present in the pancreas. Mostly it's the childhood disease, but under very rare conditions, we can also manage this as an adult disease. No cure is available for this. Once a person is diagnosed with type 1 diabetes, he has to take insulin all throughout his life. And several factors have been implicated, but nobody really knows why is it that some individuals develop type 1 diabetes and some not. And both genetic and environmental factors have been implicated. Overall, the incidence is much lower compared to type 2 diabetes, but in Western population, there is a significant increase in type 1 diabetes compared to the Indian population. In India, even now, the incidence of type 1 diabetes is pretty low. Now, let me introduce type 2 diabetes. So, diabetes, if you see it as a spectrum, like even though it is a single disease, it is actually a spectrum. At one end of the spectrum, we have the type 1 diabetes, which is an autoimmune disorder, which is a childhood disorder, which arises due to the loss of pancreatic cells. Exactly at the other end of the spectrum, we have the type 2 diabetes, which is more like an adult disease, which arises not due to insulin deficiency, but problems due to insulin action. So the common denominator for both the diseases is obviously your insulin and of course your blood glucose level. Now in this particular case, the pages do produce normal amounts of insulin, but for some reason, insulin is not able to bring down your blood glucose level. Now this phenomenon has been called as insulin resistance or resistance of insulin target hormones. The exact etiology of this insulin resistance is not clearly known, but people have speculated like type 2 diabetes basically arises due to resistance of insulin action, which is basically due to inflammation associated with insulin resistance, and this in turn leads to impaired glucose tolerance and finally type 2 diabetes. The exact role played by the immune system in this particular condition is not clearly known. The inflammation which is typically seen in type 2 diabetes is chronic, non-specific, low grade, which is in contrast to the inflammation which you see in type 1 diabetes, which is overt autoimmune response. And inflammation, whether the role of inflammation is the cause or the consequence, is not clearly known. More importantly, even though these patients have tremendous amounts of inflammatory markers in the serum, they have a poorer immune system. So how the inflammation actually impacts on the immunity of these individuals is not well studied. Okay, now that I have introduced inflammation to you, inflammation is a focal point for type 1 and type 2 diabetes, and that is also the focal point for healing and comes into the picture. So before understanding this complex mechanism, let's have a good idea about the role of inflammation in type 1 and type 2 diabetes. So as we told you, even though the diseases have completely different etiology, the common denominator between both these diseases is of course are inflammation. Both in the case of type 1 or type 2 diabetes, inflammation typically starts as an organ-specific inflammation, which is typically associated with redox stress. So in the case of type 1 diabetes, this auto-inflammatory reaction actually kills the pancreatic beta cells, which leads to insulin deficiency and type 2 diabetes. Whereas in the case of type 2 diabetes, it actually affects your target organs of insulin. Of course, every single nucleated cell in the body is a target organ for insulin, but the most predominant ones where it brings about an overt effort is your liver, adipose tissue, and muscle. And so what happens is when these organs get inflamed, it leads to insulin resistance and typically type 2 diabetes. So why should we actually study these inflammatory pathways? So by studying these inflammatory pathways, which typically occur during early stages of the disease, probably we can come up with better strategies to either halt or delay the onset of this disease. So irrespective of whether it is type 1 or type 2, typically at later stages, inflammation becomes more systemic, where you see a tremendous increase in the inflammatory markers in your blood. This is again associated with redox stress, and then Now this leads to a condition called vasculopathies. So if the major blood vessels are affected, it leads to a condition called macrovasculopathies, typically of cardiovascular diseases. I'm sure all of you know that patients have an increased risk for cardiovascular diseases compared to vascular disease. In the case of smaller blood vessels, it leads to the more typical complications seen under gravity conditions, namely retinopathy, neuropathy, and nephropathy. Apart from that, the inflammation which we are talking about is actually non-infective in nature because diabetic subjects are highly susceptible to infections. They also have problems with impact wound healing. So by studying the causes of inflammation under these late conditions, probably you can come up with strategies which can either solve or delay the onset of diabetic complications. Out of all these various avenues which are typically open for an immunologist, I decided to go on susceptibility to infections. So the first question which we asked was, what is the prevalence of filariasis among type 1 diabetic subjects? It is a very straightforward question because that is what the hygiene hypothesis is. If you have too much of hygiene, then obviously your autoimmunity comes up. So the study detected we typically had two populations. One is the normal glucose tolerance for the control group, which is around 560 glucose, then the type 1 diabetic patients who are 200. Of course, the figures are lower because, as I told you, the prevalence of type 1 diabetes is much lower in India. The current figure is around 0.5%. So we had a huge serum bank. The serum samples were screened for filariasis both by an ELISA method as well as an ICT card method. So we picked up those individuals who are filarial positive. Then we also mentioned the anti-filarial antibodies in the serum. Typically, we measure, like IgG and IgG4. I will tell you why this IgG and IgG4 values are very important. And these antibodies were measured against the filarial antigen DNA. So as you can see, the prevalence of filariasis among type 1 diabetes is almost 0%, which means all the 200 individuals who were screened for filariasis were found to be negative. Now coming to the NGT population, the prevalence was slightly higher. It was 2.5%. And the blue bar here actually represents the results obtained with the ELISA method and the black bar ITT card method. So irrespective of whichever method which we are using, we landed up with the same findings. Then we looked at the antibody titers. So as you can see, both IgG and IgG4 values were typically lower in the type 1 diabetic subjects. Now this was interesting because the IgG levels were expected because diabetic people typically have problems producing antibodies. Overall, the antibody titers tend to be much lower than the control population, and this is one reason why these people become more susceptible to gram-negative bacterial infections, which are typically antibody-mediated. Now, the IgG4 level was also lower. IgG4 is interesting because IgG4 against the filarial antigen is highly specific for exposure. Now, coming back to filaria, there are various stages of the disease. One is the patient can actually be bitten with a mosquito and the parasite can enter into the body, which will expose the body to the filarial antigen or the filarial pathogen. Now this condition is typically called as exposure. Not all individuals who are exposed to the filarial parasite will get disease. So out of them, only a small percentage get infected, and out of infected, only a small percentage will develop the disease. So even though in a clinical setting you see only the end result, which is the disease person, there are several steps before that. And the population who are actually exposed is much larger than the population who are actually getting disease. Now, IgG4 is actually a marker for exposure. So typically when you have lower IgG4 population, it means those persons are not been best exposed to the filarial antigen. Now we do not know how to explain this phenomenon for the simple reason that all these subjects are from the endemic population and everybody is exposed to mosquitoes. In fact, the moment a child is born in India, it is bitten by mosquitoes. In spite of that, why is it like only a small population of these unfortunate individuals are not even well exposed to the filarial pathogen? It's very marvelous. Okay, this is the story about type 1 diabetes. So since we got this interesting result, we wanted to extend that one. Typically extended to a metabolic disease, that is your type 1 diabetes. So the statistic is almost the same for both the studies. So here, instead of 1 group, we had 4 groups for simple reasons like the prevalence of type 1 diabetes is around 18% currently. And since we were part of an economic study, we had entity samples were the control samples. We also had newly diagnosed ITT samples for the pre-diabetic subjects. Then we had newly diagnosed diabetic subjects and the non-diabetic subjects. The finally screening and antibody titers was carried out exactly like the first study. But in this study, since we had a large number of serum samples, we also wanted to go in depth and try to have a glimpse about what happens to the immune system, which we have been already speculating under the conditions of this coincidence. So we looked at the serum cytokine levels by a high throughput method for the multi-beam array system. And these are the serum cytokines which we looked at. So like diabetes, the prevalence of filariasis was much lower among your disease subjects compared to the normal subjects. What was more interesting is there was a linear trend which was seen, and the linear trend was actually decreasing as we went from NTT to pre-diabetic to diabetic subjects. Then we looked at the finally antigen titers. The antigen titers were also more or less the same pattern. We had more or less equal amount of serum antigen titers in the NTT and pre-diabetic group, but the moment they become diabetic, then the serum antigen titers got upgraded. Then the antibody titers, and here I would like to specifically note the difference between IgG and IgG4. And as you can see, the IgG levels are here, which is typically expected because, as I mentioned to you, diabetic patients, whether they are type 1 or type 2, they have problem producing antibodies. But what was interesting in the case of type 1, if you remember right, like there was a decrease in the IgG4 levels, whereas in the case of type 2, there was no difference seen with respect to IgG4 levels. This is the typical picture which we expect in an endemic country, because individuals are exposed to mosquitoes and everybody who is exposed to the filarial pathogen would typically produce IgG4, which is a marker for exposure. So what it clearly says is like all these individuals are equally exposed to the filarial pathogen, but for some reason the disease condition seems to be more prevalent among the non-diabetic compared to the diabetic population. So as I mentioned to you, then we aim for looking at the cytokine profiles in order to have an understanding about what happens to the inflammatory component under the coincidence of these two diseases. So first we looked at the pro-inflammatory cytokines, namely TNF-alpha, IL-6, IL-1 beta, and CSUF. Now we selected these four pro-inflammatory cytokines because these are the master regulators of inflammation. Now the first two groups are actually your control groups of the entity group. If one is phylated negative, the other one is phylated positive. The last two groups are diabetic group. Again, one is phylated negative, one is phylated positive. Now, as expected, as you can see, there was significant amount of serum cytokines in the diabetic population, which is indicative of inflammation. But what was not expected is, we expected a synergy between these two conditions and more higher levels of serum cytokines under conditions of both diseases. But what we found out was, when diabetic people were positive for filariasis, they typically had lower levels of the pro-inflammatory cytokine compared to diabetic people who are negative for filariasis. This is very clear indication saying that filariasis is actually down-modulating your inflammation, and that's why you see a decrease in your serum cytokine levels. Then we look at TH1 and TS17 cytokine. Now, apart from the pro-inflammatory cytokines, we also have other cytokines which are also equally important for both inflammation as well as immunity. Now, T cell cytokines are typically produced by T cells and they come under various categories. You have TH1, TH2, TS17, and the numbers are actually increasing. So here, for this study, we just looking for the master or the signature cytokines of TH1 and TH2 response. And as you can see, interferon gamma levels and IL-2 levels were slightly higher, not higher, interferon gamma levels were higher, but then interferon gamma level was not affected by your filariasis status. Then we look at TH2 cytokines, your IL-4 level and IL-13 levels were higher. Again, these cytokines were not affected by the filariasis status. So what this clearly says is, yes, filariasis is actually able to bring about down-modulation of inflammation by immunomodulation, but this seems to be highly specific only to a particular group of cytokines, namely the pro-inflammatory cytokines, but not to your other cytokines, namely the T cell cytokines. Point number one. Then another important lesson which was learned is, it seems just by down-modulating the pro-inflammatory cytokine of your insulin resistance and probably type 1 diabetes. So since we got this interesting findings, we wanted to extend this one to a more global condition called as metabolic syndrome. Now let me introduce metabolic syndrome to you. This is more common compared to your type 2 diabetes because type 2 diabetes itself is a component of your metabolic syndrome. Now metabolic syndrome has been named by several names like syndrome X, insulin resistance syndrome, Draven syndrome, so on and so forth. So typically in the Indian population, the prevalence of type 2 diabetes is 18%, the prevalence of metabolic syndrome is 30%. Now the question is, what exactly is a metabolic syndrome? Now metabolic syndrome is a conglomeration of several metabolic disorders, not just one. And this includes dyslipidemia, obesity, hypertension, and diabetes. Now under dyslipidemia, we have two different components. One is high levels of triglycerides and low levels of HDL cholesterol. We remember the biochemistry, HDL cholesterol is a good cholesterol and low levels of HDL cholesterol is actually bad. And triglycerides are actually bad for health and high levels of triglycerides can actually make you more susceptible to cardiovascular disease. So the question is, why do we really need to classify and study all these things? We need to do this one because metabolic syndrome as a single entity serves as a major risk factor not only for cardiovascular diseases but for a lot of nephrotic conditions or kidney diseases. Now all these values have been defined by the NCP ATV3 study. Study design, again, more or less the same. So here we had two groups. One is the non-MS group and the other one is the MS group. Filial training antibody detection was carried out. Then we also looked at, but for this study, instead of just looking at the cytokines, we wanted to have a better understanding of what is actually happening. So we actually looked at hormone levels because it is the hormone, not just the insulin, which control your blood glucose level and other lipid parameters. Again, the hormone estimation was done by high-throughput method was the biometric method. So what we did was we took a huge serum bank and then we started chopping it by various definitions. So first we stratified the population based on diabetes and that is exactly what we got. Then we stratified it based on obesity. Again there was a reduced prevalence of AS. But now when we stratified the population of hypertension, the different prevalence of AS was completely lost. Then when we did it with high levels of triglycerides and low levels of HDL, which are conditions of dyslipidemia, again the differential prevalence was lost. But when we took it as a metabolic syndrome, there was a significant difference between the non-metabolic syndrome and metabolic syndrome population, which is basically due to the additive effect of diabetes and obesity. Now what does this really mean? Yes, Vivekanandhan is able to control protection and certain metabolic diseases like diabetes and obesity, but it is definitely not like a magical potion which can control protection against all metabolic diseases. Point number one. The second thing is that disease pathogenesis, even though we are classifying all of them as metabolic diseases, seem to be slightly different from one condition and another condition, and what is the difference is something which has not been understood till now. So then we looked at the antigen levels are actually exactly like the prevalence data. And then we looked at the antibody titers, which was more like that of type 2 diabetes. And then we looked at HSCRP and antibody titers. Now HSCRP is actually a serum marker for inflammation. What was interesting in this study, we actually never measured the HSCRP and antibody titers. These values were measured as part of the biomarker analysis around 10 years back before we actually did this study, but for the same serum sample. So since we did the failure screening, we went back to the subjects, to the organization, got the raw data. What we did was just did the stratification. And you can see that these values are actually reflecting our hypothesis. So generally under conditions of diabetes or metabolic syndrome, your HSCRP levels are typically higher because these people have inflammation. And your adiponectin levels are typically lower because adiponectin is a potent hormone which can protect you against metabolic diseases. That is exactly what you see here. So the last two, in the second picture here, you can see like they typically have high levels of HSCRP, and in the first picture, you can see like the orange color boxes have typically lower levels of your adiponectin. But the moment you stratify the subject based on the physical status, even among control subjects, you can see there is a dip in HSCRP levels and increase in adiponectin levels, clearly indication of protection against metabolic diseases, which We found out like metabolic syndrome patients with metabolic syndrome typically are expected at very high levels of insulin levels, which is indicative of your insulin resistance. But this insulin level was not very much affected by your biliary status. It was sort of unexpected. Then we looked at the adiponect gene profile. Adiponect genes are actually a group of hormones secreted by your fat cells. So typically what happens under conditions of metabolic syndrome or diabetes, these people are obese and have a lot of fat cells. And these fat cells are not able to perform the function properly, and that leads to the disease condition. So now adiponect genes are coming up a very big way in studies of metabolic diseases. So we looked at leptin, which is adiponect genes strongly associated with obesity, and we looked at resistant 5-bispacking. But then Tilarius or the disease conditions, other disease conditions, namely the metabolic syndrome, we didn't have much effect on these hormone levels. Then we looked at the gastric hormones or the gastrointestinal hormones. Now these hormones have been recently discovered compared to the other hormones for the simple reason that they are secreted by the gastric epithelium, which has been traditionally more associated with digestion and absorption. But now the present concept is that every cell in the body is able to secrete one protein or other, or one hormone or other, which either has a direct or indirect effect on metabolism. And in that aspect, the gastric hormones which are secreted have come a big way, because these are the first set of hormones which signal your pancreatic cells to secrete insulin. So if there are no gastric hormones, obviously your insulin secretion is attenuated. Then what we found more interesting is Tilarius seem to play a very important role in abrogating this gastric hormone, namely ghrelin, GLP and GLP. And this is very interesting because now it tells us a completely different dimension apart from an immune mechanism which might be operating under conditions of Tilarius conferring protection against the metabolic system. So finally, since we are done with type 2 diabetes, metabolic syndrome, we wanted to know what is the effect of Tilarius on the end disease, namely the cardiovascular disease. So cardiovascular disease, as we know, it is variously named. The most common name is atherosclerosis or atherosclerotic heart disease. Now this is basically due to the thickening of the coronary artery. The major artery which supplies blood to your heart muscles. So because of this thickening, blood flow is sort of attenuated, and because of that, the patient develops hypertension. And finally, the whole head vessel is occluded, and it sort of constricts the blood flow to your heart. So now this brings the acute condition called myocardial infarction, where the patient actually dies because of no blood supply to the heart. It is a very life-threatening condition, and the prevalence of the disease was increasing. And diabetes serves as a major risk factor for cardiovascular disease. So lipid-loaded macrophages or the bony macrophages are the main players in this condition. These sticky macrophages go and obstruct because they won't stick onto the blood vessels and sort of obstruct the blood flow. And type 1 and type 2 members, all of them serve as major risk factors for cardiovascular disease. But it is exactly the same. Wow. So in this particular case, as you can see, there was no difference with respect to the prevalence of Tilarius in patients who had cardiovascular disease and who didn't have cardiovascular disease. What is important here is, for this study, we actually excluded all the patients who had diabetes because we don't want any interfering effects because of diabetes. So this clearly says, like, even though diabetes serves as a major risk factor for cardiovascular disease, persons can develop cardiovascular disease in the absence of diabetes, and the pathogenesis might be slightly different under these two conditions. One is sensitive to phenylated inflammation, the other is not. So the antibody titer, again there was no difference. Cytokine pattern, there was a slight increase in pro-inflammatory cytokines, but it was expected because they are having cardiovascular disease. Again, there was no difference in the adipocytokine profile. Yeah. So what it says is, like, even though we are classifying all of them as metabolic diseases, the most important thing is, even though these typically come under inflammatory condition, the kind of inflammation associated with each and every metabolic disease is slightly different. And you cannot really jumble everything together and call it as inflammation or metabolic diseases. More amount of studies have to be taken out in order to decipher the subtle differences in the inflammation associated with these conditions. And then it is very important that only certain inflammatory pathways seem to be sensitive for phylated immunomodulation and not all. So when we we were publishing these kind of results. There was a very interesting paper which was published by University of California, Davis. And what they did was they took our media and tried to study the mechanism in animal models. So they took mice and then they had two groups of mice. One was infected with filariasis, the other one was not infected with filariasis. And then they tried to induce diabetes in this infected and non-infected mice by a procedure called diet-induced obesity or the DIO mice model. And what they found out was, as you can see, infected animals typically had lower levels of the blood glucose level and lower levels of insulin resistance, directly providing support to the findings which we have come forth, which we have deciphered in the human population. Our clinical findings were sort of, recapitulated in an animal model. So to sum up, let's again go back and start with the hiding hypothesis. So what the hiding hypothesis says is, infections like bacterial infections can actually confer protection against allergies and autoimmunity by means of immunomodulation. Now they do this one by a variety of mechanisms. Like I have mentioned at least 6, there might be at least 50 or 60 examples. All these immune modulated mechanisms are typically classified into modified T response, and the end result is more or less the same, namely the down-modulation of inflammation. So this is something which was already known in the literature. We took an idea from this one and tried to extend this one, and what we found was the same mechanism need not be restricted only to allergies and autoimmunity, but in fact the implemented down-modulation can confer significant protection against insulin resistance as well as metabolic syndrome. So since we are extending this hiding hypothesis, which was traditionally restricted to allergies and autoimmunity, we are calling this one as extended hiding hypothesis. So what does it mean? Does it have any practical implications? So as I told you, animal studies have proved the same thing, clinical studies have proved the same thing. Right now we are taking up cell models to identify the exact ideal component which is able to downmodulate the inflammation. So in case, if we are able to go on in this particular direction, probably in future this can pave the way for a futuristic diabetic vaccine as well as diabetic drugs. So we definitely need a diabetic vaccine because as you know right now there is no vaccine which is available against diabetes. And then even the anti-diabetic drugs which are commercially available except for obviously the metformin has severe side effects. So some sort of biological which is able to downmodulate inflammation and thereby bring down your blood glucose level is definitely a welcome change. So before I take the talk, I should obviously acknowledge my collaborator. So I should first acknowledge Dr. Morgan, who is the chairperson of Metadiabetes Association, who was instrumental in conducting these epidemiological studies and storing the serum samples. So without those serum samples, all the studies would have been impossible. Then my collaborator, Dr. Babu, and he is an AI scientist who actually works on immune response and the conditions of diabetes. So we both collaborated, he looked at the filariasis side and I looked at the diabetic side. So that's how the both studies No, actually we haven't looked at allergies per se because we wanted to be more focused because there are so many other groups which are looking at allergies, autoimmunity and things like that. So we thought we will just restrict ourselves only to metabolic diseases. So with no more questions, I again thank the organizing committee once again for this giving me this opportunity. Thank you.
As one last gift of appreciation, we wanted to present you with a small gift for you. So let's all give a warm round of applause for Dr. Vivekanandhan. For those of you who are sticking around, up next we have student oral presentations that will be held in here as well as in Hedderbrink, which is right outside. And later on in the day at 5 p.m. we will be having another keynote speaker, Dr. Bob Ballard, who will be speaking on his deep sea exploration and the importance of studying oceans. Thank you.